Chapter 8 will review in a tabular format drugs of abuse. You'll recognize that most of the information in that small chapter has been covered but scattered throughout the book. As such, if you want a nice synoptic view of most of the drugs of abuse, you have it right there. On your exam, we like to know the mechanism of action of the primary classes of drugs of abuse, of course the toxicities, and the associated issues with withdrawal. The first group of drugs of abuse we will review are the CNS stimulants. The CNS stimulants which are illegal are cocaine and amphetamine, unlike caffeine and nicotine. Cocaine and amphetamines work on norepinephrine, dopamine, and serotonin. And we remember well that cocaine can block dopamine, norepinephrine, and serotonin reuptake, and has otherwise local anesthetic action as a sodium channel blocker. It is primarily the increased dopamine that we associate with addiction. For amphetamines, we've seen them so far primarily as releases of amines from the mobile pool. Well, notice that amphetamines can also block reuptake and even be weak MAO inhibitors. As such, there's no doubt that amphetamines do everything pharmacologically sound to be psychostimulants. If one day you need a quick fix and figure out what does norepinephrine, dopamine, or serotonin do in my body, well, you have it right here. Increased norepi in the periphery is sympathomimetic with increased heart rate and contractility. What receptor? I'm sure you're saying beta 1. Blood pressure changes, particularly hypertension, with alpha 1 stimulation. And very classically, those dilated pupils that are a sign that someone might be on a drug of abuse such as cocaine or such as amphetamine. Mydriasis from radial muscle stimulation by the alpha 1 receptors. Well, central excitation, hyperactivity, these are some of the stimulant effect of norepinephrine. Increasing dopamine, on the other hand, is what we will associate with psychotic episodes in those users of psychostimulants, potential paranoia, delusions, hallucinations, and quite possibly in the nigrostriatal pathway dyskinesias, and in the pituitary hypothalamic axis, endocrine disturbances. Namely, we always worry with increased dopamine of hypoprolactinemia, the issue, of course, of anorexia and temperature changes. For serotonin, behavioral changes are the primary issue with the aggressiveness. And when you put all this together, you have a patient here who's an abuser of stimulant and who can become rather dangerous when they're craving for the drug because of all these aggressiveness causing type of neurotransmitters. In toxicity, it's an extension of the pharmacology. Too much norepinephrine will result in cardiac arrhythmia, too much vasoconstriction will cause ischemia, and the classic mode of death will be myocardial infarction or strokes. With the excess dopamine, the behavioral aspect of a patient is really hit with major psychosis, what we sometimes refer to as cocaine delirium. Finally, with excess serotonin, let's not forget the potential for life-threatening seizures from the possible serotonin syndrome. So these are drugs that are very toxic in overdose that generally will result in death of the individual. On withdrawal, if you remove a CNS stimulant, you should not only have craving for the stimulant, but severe depression, anhedonia, you don't feel good. And there is no antidote to any of this, neither to the toxicity nor to the withdrawal, potentially the use of antidepressant to ease the depressive mood of a patient coming down from stimulants. Overall, everything is supportive management. Your next group of drugs of abuse are the CNS depressants. And in the CNS depressants, the primary one is no doubt ethanol itself. But as far as prescription drugs, benzodiazepines and barbiturates were classically associated with abuse liability, and common to all three, their interaction with GABA. Let's remember then that whereas benzodiazepine potentiate the effect of GABA, recall that they increase the frequency of opening of the channel, barbiturates and ethanol prolong the activity of GABA and can even open the channel at high doses. They are GABA mimetic. This is the GABA-A receptor we're talking about, and benzos have two sites for them, BZ1 to mediate sedation and BZ2 to mediate all the cognitive impairment. Well, whereas the effect of a benzo is light to moderate CNS depression, we know that barbiturates and ethanol were reviewed as causing any levels of CNS depression, including at high doses, respiratory depression, coma, and death. The toxicity of benzos is potentially reversed with flumazenil. There are no antidote to the severe CNS depression of barbiturates and ethanol. And the withdrawal of CNS depressant is that of stimulation, primarily rebound insomnia, rebound anxiety, rarely seizures for benzos, life-threatening seizures for alcohol and barbiturates. You remember the IV benzos that I used for that? I'm sure you're saying IV lorazepam is one of the ones that we like the best. Lorazepam or also diazepam being used IV, a long-acting benzodiazepine. Opiates were also reviewed in that big section, and opiates are classically abused either as a street drug heroin, which is not available in the United States for medical use, but also with medical opioids such as morphine, the fentanyls, methadone, and other opioids such as hydroxycodone that we were mentioning were causing big problems lately. I doubt the boards will ever ask you about the neurotransmitters that are involved here, being that really we're looking at a system that was controlling, modulating the action of other neurotransmitters. Rather, they're more likely to ask you about the opiate receptors, mu, kappa, and delta, OGI coupled, and the fact that it is the mu receptor activation that has the biggest link to abuse liability. It is probably the fact that somehow it increases dopamine transmission in the mesolimbic system. By the way, in your behavioral sciences, if you've seen them already, one of the limbic system area where dopamine increase is associated strongly with addiction is what we call nucleus accumbens. And I've meant to tell you this throughout the tape, and I keep on forgetting. So no better place than to do so when we talk about drugs of abuse, no doubt. Well, the effect of a morphine-like drug. Euphoria. The patient feels good, but also analgesia, sedation, cough suppression, constipation. Remember, we do not develop tolerance to constipation, and we do not develop tolerance to the strong meiosis. Look, we even reminded you, except meperidine. Can you tell me why? Yes, because meperidine is not only an opiate, it's also an antimuscarinic medication. Well, the toxicity of opiate is the triad of respiratory depression, coma, and of course, pinpoint pupils. How do we reverse the respiratory depression? With the antidote, naloxone. Don't confuse with naltrexone that is used for the craving to these drugs. Withdrawal had the hallmark feature of causing an increase in sympathetic activity. This increased sympathetic activity could be managed with drugs such as clonidine, and methadone had to be given, particularly to manage the centrally originating pain. Withdrawal to an opiate is not life-threatening. As a matter of fact, out of all these drugs, opiates, CNS depressants like benzos, barbiturates, and ethanol, and CNS stimulants such as cocaine and amphetamine, which ones have a life-threatening withdrawal? You are correct if you answer barbiturates and ethanol because of status epilepticus. So here are the only drugs of abuse we have not mentioned, hallucinogens. And we owe it to our boards a couple questions and points, therefore, about cannabis or marijuana. Cannabis involves many receptors and many neurotransmitters, but overall, that modulation effect that is so classic of drugs of abuse is through the interaction of THC, which stands for tetra, that's the T, hydro, that's the H, cannabinol, that's the C. And you recognize in cannabinol cannabis, the other name for the plant. The whole idea is that this THC interacts with at least to date 2 different subtypes of receptor. CB1 is the one that is primarily found in the CNS, the one to associate with the actual addictive potential. CB2 is primarily recognized in the periphery. As a matter of fact, CB2 receptors are found a lot on immune-competent type of cells and allows endogenous cannabinoid molecules to behave as immunomodulators. As far as effects of cannabis, it is a mild CNS depressant with sedation. It causes happiness in people who smoke it, euphoria, and has as a potential nasty issue the fact that it causes significant tachycardia. These palpitations are secondary to vasodilation and hypotension. Well, this hypotension through vasodilation can show actually very well in the eye once again. But this time you are not going to focus on looking at your patient's pupil, rather your patient's conjunctiva. There will be red, what we sometimes refer to in emergency room as rabbit's eyes. And that comes from the strong vasodilation associated with the use of cannabis. Delusions and hallucinations can occur at very high doses. What is an important effect that is not mentioned here is the fact that they will increase eating. These are drugs that will cause what sometimes people refer to as the munchies. Now, I'm telling you this because we already use cannabis in medicine. And I'm not talking smoking pot in medicine here. I'm talking using THC as a parenteral or as an oral preparation. THC has been marketed for beyond a decade as the drug dronabinol. And when I'm writing the word dronabinol, you see nabi in it like cannabis. Dronabinol is used in wasting. Wasting could happen because of HIV, because of terminal cancer. And dronabinol is also used as a strong antiemetic. We'll mention the chemical dronabinol in one of our last sections in the book when we talk about antiemetic. So it won't hurt if you add it at this point, so you recall it better later on. Other hallucinogens involve compounds such as LSD, such as peyote, and so forth. These are poorly understood. The only thing I've ever heard over the years being board tested is the interaction with serotonin is how they want the hallucinations to occur. Because they're poorly tested, of course, there's no reason to go any further with those. As far as toxicity, hallucinogens can be associated with flashbacks. And flashbacks occur with cannabis as someone who is not taking the drug but suddenly behaves and feels as if they were under the influence of that drug. There's very little understanding as how this happens. The withdrawal of anything that is sedating and causing euphoria is primarily those of irritability and anxiety, which results in the patient, of course, relapsing and using more cannabis. I think maybe an untold truth of the use of cannabis is the issue of smoking. Because you are smoking a cigarette with a joint of cannabis in it, you suffer the same pathologies that we see associated with cigarette smoke. That is the potential for lung cancers, renal cancers, bladder cancers, the cardiovascular disease increase with hypertension, ischemic condition of the heart, the risk of strokes, and so forth. So this is something not to be underestimated in cannabis users. To finish this chapter, miscellaneous abuse drugs. Out of this group, let's remind ourselves of ketamine, the drug that was an analog of phencyclidine, PCP, and as an NMDA receptor antagonist, blocking the effect of glutamate, it caused, in our chapter of anesthesia, our little patient to have vivid nightmares, hallucinations on emergence. Look, PCP is just a ketamine on hormones in a way, and PCP is actually causing tremendous problem with overdoses resulting in convulsion and death. It's extremely toxic. PCP has a complex pharmacology. It also likes to stimulate nicotinic receptors in the muscle, and as such causes tremendous strength in people who take PCP. It might require several law enforcement agents to literally calm down someone on phencyclidine. These are people that can walk through a wall, flip a car by themselves. They have superhuman strength. Of course, in that process, they can suffer rhabdomyolysis and acute tubular necrosis. So certainly not a nice drug addict to be dealing with in your emergency room. Depending on where you practice in the country, you will meet PCP users. Ketamine as a drug of abuse is often referred to as Special K. So it's always made me laugh when in the Miami area they talk about it as Special K, you know, as if you were going to get your vitamins in the morning by having your cereals right there. It's often obtained by individuals from veterinary ketamine, much easier to get than the one used in hospital. As far as the anticholinergics, that has always surprised me. How could someone, particularly a young person, get a kick out of dry mouth, blurred vision, constipation, and urinary retention? Now, of course, these are peripheral effects of atropine-like drug in the brain. Antimuscarinic cause some nice CNS depressant effect, and as such, depending on the dose, can cause disinhibition or can cause a nice mellowing, just like you would get from alcohol. Problem with atropine-like compound: the fact that they can cause torsade, the cardiotoxicity, convulsions, and coma in overdose. These are generally teenagers who are using plants that are well known to grow along the sidewalks of most places in the country, such as Jimson weed, or in more tropical or warm areas, such as in South Florida, angel trumpets. And what they do is either prepare some teas or literally smoke the leaves. Then they end up in the emergency room, and quite often actually in the autopsy room of a medical examiner's office. Let's hope they died happy. As far as designer drugs, these are chemists that are working, if you want, on the dark side. They're probably making much more money than you and I, but they have a very, very complicated life to lead, I'm sure. The idea is to build drugs based on knowing the receptors to bind to and the effects of chemicals in the brain. This is where amphetamine-like compounds such as ecstasy, MDA, MDEA would belong. These are chemicals that have a strong serotonin pharmacology, therefore can cause hallucination, but they're also strong stimulants. So what you need to worry about here are, again, young people, particularly going to what we call raves. And raves are these incredible parties that would go on all night long, where under the influence of these drugs, these youngsters can actually go literally crazy, avoiding drinking, and the big issue is for them to die of the consequences of dehydration or renal failure during these rave parties. Finally mentioned here, inhalants. Inhalants are so easy to get that this is often a road to addiction. To use glue and sniff it, to use literally pressurized gas in cans such as deodorant like Axe, or such as creams and so forth like whipped cream, and to literally spray this in your nose or in your mouth, breathe it deep, and have the effect of the inhalant. Inhalants are like the gases of general anesthesia. So the idea for these individuals is to suffer some CNS depression. Problem are all the solvents in those cans, and the solvents will cause multiple organ failure, particularly liver, kidney type of failure. One of the worst cases I've ever worked on myself is someone using the actual pressurized can to repair tires and blowing this up their nose. Of course they died, hopefully happy, because the next thing you know, all of their airways were filled with a gummy type of substance. How stupid can one get? This concludes Chapter 8, Drugs of Abuse, and ends our CNS section.